Invasive infections due to non-typhoidal salmonella have increased steadily since World War II. Several risk factors for salmonellosis include extremities of age, immunosuppression, chronic liver disease, hemoglobinopathies, malaria, schistosomiasis, and chronic granulomatous diseases. Alterations of the gastrointestinal tract also predispose to progression from enteric to systemic salmonellosis. Non-typhoidal salmonella bacteremia is relatively rare in the United States, and many cases of salmonellosis go undiagnosed, yet it is responsible for the largest number of hospitalizations and deaths related to foodborne illnesses. Therefore, physicians should be aware of the possibility of non-typhoidal salmonella bacteremia in high-risk patients with prior history of abdominal surgery. In our case, a 59-year-old chronically bedbound male with a past medical history of hypertension, diabetes, small bowel obstruction, and intracranial aneurysm rupture complicated by paraplegia and epilepsy presented to the emergency department with a chief complaint of 4-day history of non-bloody diarrhea with associated fevers. He denied any recent travels, ill contacts or visitors, or changes in his diet or medications. His past surgical history was significant for an open appendectomy due to perforated appendicitis with subsequent laparoscopic cholecystectomy and lysis of adhesions. CT abdomen in the pelvis with IV contrast showed non-diluted loops of colon and a small bowel with short segmented dilation. Short segmented loop of small bowels was dilated to 8.4 centimeters and contained an air fluid level with associated enteric suture. On admission, patient's temperature was 101 degrees Fahrenheit and white blood cell count was 6.1. Serum lactate was 2.2 and he was admitted for possible viral gastroenteritis. He was started on Flagyl 500 milligrams PO Q8 hours as well as IV maintenance fluids. On the second day of admission, his lactic acidosis had resolved, but he continued to have fevers with a Tmax of 101.4 degrees Fahrenheit. Stool cultures at that time were negative for oviparasites and C. diff toxin. On the third day of admission, the patient was now without fevers for over 24 hours. Blood cultures returned back positive for gram-negative rods, and he was started on empiric Rocephin 2 grams IV Q8 hours. On the fourth day of admission, the stool and blood cultures returned back positive for Salmonella species type C. Stool cultures for Campylobacter antigen, Shigella species, and Shiga toxin returned back negative. He was treated with Rocephin 2 grams IV Q24 hours for 5 days, after which he was discharged on a 14-day course of levofloxacin. Non-typhoidal salmonella bacteremia is relatively rare in the United States, and many cases of salmonellosis go undiagnosed, yet it is responsible for the largest number of hospitalizations and deaths related to foodborne illnesses. Because of this, it is important to understand the different risk factors that contribute to the public health burden. In one study, they found that most adult patients with serotype bacteremia had obvious risk factors, including malignancy, liver cirrhosis, and systemic lupus, or previous use of corticosteroids. Subsequent local infections with septic arthritis, pneumonia, and peritonitis, or cutaneous abscesses were noticed in about 21% of these bacteremic patients. Postoperative infections with salmonella is rarely encountered and typically only reported in prosthetic replacement surgery and intracranial surgery. Alterations of the gastrointestinal tract also predispose the progression from enteric to systemic salmonellosis. Alterations of the gastrointestinal tract predisposes the progression from enteric to salmonellosis, and certain types of salmonella, although rare, are more likely to result in invasive infection than gastroenteritis alone. Our patient presented with symptoms of enteric salmonella infection. However, he had multiple risk factors, as we mentioned, for development of invasive salmonellosis with bacteremia, including multiple complex abdominal surgeries with ruptured appendix and small bowel obstruction, as well as intracranial aneurysm with lasting complications of paraplegia and chronic constipation. Additionally, the patient had undergone chronic intestinal pseudoobstruction secondary to the neuropathic insult from his hemorrhagic stroke, diabetes, and multiple surgeries. In these conditions, which allow for chronically decreased perfusion, innervation, and breakdown of the mucosal barrier of the intestine, this creates the perfect storm for an infectious invasion from the enteric system into the bloodstream. Approximately 1% of enteric infections with non-typhoidal salmonella result in bacteremia, although the true rate of bacteremia is unknown, as many primary enteric infections are not microbiologically diagnosed. Because of this, salmonellosis presents a major ongoing burden to public health, and physicians should be aware that patients with multiple comorbidities including abdominal and intracranial surgeries, can have a compounding increased risk for Salmonella bacteremia.